Dear Chairman, dear colleagues and friends, ladies and gentlemen, today's talk would be about shock waves in erectile dysfunction treatment. I have nothing to disclose. Low-intensity shock wave therapy was introduced back in 2010 by a team of Israeli urologists led by Dr. Yoram Vardi. And they based their hypothesis on previous experimental findings that shock waves may improve erectile function and blood flow through an increase of vascular angiogenesis in the penis. These findings were further investigated by the same team by randomized double-blind sham-controlled study, which concluded and confirmed that there is a positive short-term clinical and physiological effect on erectile function. We can see here very clearly the significant increase in the erectile hardness score and the IIEF score. And now, research, clinical, and commercial interest has grown significantly. There are several machines out there labeled for low-intensity shockwave therapy, and this market is expected to increase significantly by 2025. But is it a first-line treatment? The EU guidelines included in first-line treatments for erectile dysfunction without clear and definitive recommendations in anticipation of larger RCTs with longer follow-up. On the other side of the Atlantic, the AUA makes no reference to list, and FDA approval of devices is pending. So if we take into consideration that none of us has exposure to list during residency, it is absolutely reasonable to have a lot of questions when list comes to mind, and I'll try to answer them as best as I can. First of all, shock waves are natural phenomena that occur during thunderstorms, blasts, and explosions. A shock wave is an acoustic pulse with very unique characteristics, a steep rise to high pressure amplitudes. This is the compression phase, and very quickly we have a gradual drop to negative pressure. This is the tensile phase. In low-intensity shockwave therapy, we use lower pressures than ESWL. We don't want to break stones, we want to promote angiogenesis. The pressure used is usually in the range of 10 megapascals, which is lower than 10% of ESWL. Currently, we are using focused shock waves and not radial shock waves. Focused shock waves penetrate and carry energy deep into the tissue. Radial shock waves are superficial. Devices of radial shock waves are cheaper, but currently are not the standard of care. There are clinical studies underway, but we should be aware of their difference when buying equipment. Historically, the first shockwave machines were electrohydraulic back in the 1980s. Then came the piezoelectric and the electromagnetic. The main problem with electrohydraulic devices is that they produce inconsistent shock waves, and there is a slight shift in the focal zone. The spark source, which generates the shock wave, tends to wear out and needs to be replaced. The electromagnetic produce very consistent shock waves, and they are durable. And so are the piezoelectric, which actually are very durable. We can see that they can last up to 5 million shocks. Perhaps the most important parameters when talking about shockwave treatment is energy and energy flux density. The energy is inversely proportional to the acoustic impedance of the tissue, which is a measure of tissue density and sound velocity in the medium. That means that we can carry energy through the human tissue because it has the same acoustic impedance as the liquids. That's why we have to use coupling, a coupling gel or a water bath. Energy flux density is a measure of the concentration of energy over a given area. And in low-intensity shockwave therapy, we use intermediate settings because, again, we don't want to break stones. We want to promote angiogenesis. The focal zone is the area where the pressure is over 50% of the peak. But most important is the therapy zone, which is the area where full biologic effect is present. This is not identical with the size of the -6 dB zone and increases with an increased energy setting. But we don't need to have a typical form of focused shock waves. We can modify it by modifying the reflectors and the sources, and we can produce wider beams that can cover larger tissue volumes with one pulse. We can see some examples over here, how we can transform the cigar-shaped focal zone of an electrohydraulic device to a wide, soft focal area, and how we can convert the tiny little focus of a piezoelectric machine to a linear one. And there are even now devices that can combine two probes in order to cover both corpora simultaneously. But what are the real differences of the device that are available in the market, at least the Greek market? Let's see. The only electrohydraulic generator today is the ED1000. The others are mainly electromagnetic, and there is one piezoelectric. They all produce focused shock waves, and this is a good thing. The system of Direx, the Renova, has a locked energy flux density at 0.09 millijoules per square millimeter. That's not a big advantage because sometimes due to energy losses, we need to increase the EFD. The ED1000 has a quite small frequency. That means that treatment takes time, and this is tedious for us. And the ED1000 and the Direx machine are considered loud, and that's annoying for the patient and for us as well if we do many treatments. And also the pain level for the ED1000 and the Aries by Dornier is high, and that's not a good thing. Please take notice that the dual FSD1 by Storz has a narrow focus. This is a disadvantage because we said again that we have to have a wide focus in order to cover more tissue. The lifespan of the applicator is a very big issue. The ED1000 has a very limited lifespan of 180,000 pulses. To have a pattern that changes penetration depth is always a good thing, but these machines don't have it, and the weight of the transducer is also important. But how does this thing happen? There is a mechanical effect, very clear, which is followed by a biologic response and a clinical result. As we said earlier, there are two phases in a shock wave. This is a compression phase with positive energy densities that causes shear stress, and then there is a tensile phase, which causes cavitation bubbles. Shear stress is a very complex thing in regard to cellular response. There are activated mechanoreceptors when shear stress is applied, and complex signaling pathways are activated, leading to the activation of the synthase of NO, production of NO, vasodilation, and muscle relaxation. There's also increased gene transcription of genes that lead to these actions. During the tensile phase, cavitation bubbles are formed in the blood vessels. These are very tiny, and when they implode, microjets are produced which cause endothelial microtrauma and initiate healing mechanisms. Overall, the tissue responds in various ways to shockwave energy. There is tissue remodeling, smooth muscle is increased, elastin fibers are increased, there is endothelial repair, there is neoangiogenesis through the VEGF pathway, and also by production of the SDF1, which leads to a homing of stem cells. There is recruitment and activation of progenitor cells that are circulating in the bloodstream, evidence of nerve regeneration and anti-inflammatory activity. And we can see this in this slide as well. But is it effective? What's the clinical evidence? It has been shown in various studies that it is effective. In 2012, this milestone publication by Vardy and co-workers showed that low-intensity shockwave therapy is better than placebo. Then it was shown that it can shift non-responders to PDE5 inhibitors to responders, and lately that it improves penile hemodynamics. This very important publication by Professor Hadjikristou shows clearly that at 3 months there is an increase in the peak systolic velocity in penile triplets. But for how long? This is a big question. This very important publication by Kitri and the Haifa team showed that there is a gradual decrease in efficacy over time in initial responders to treatment. Only 53.5% maintained this effect in 2 years, and 76% of patients with mild and moderate ED without diabetes will preserve it. That means that if we have severe ED, the results are worse in 2 years. There are a number of RCTs in the literature that have mixed results. There are studies that results are very, very poor, and there are studies that have a very high success rate. There are open-label studies as well. I think one of the most important ones was the publication by Professor Hadjikristou, which showed that we can improve our outcomes if we perform more sessions. The success rate rose up to 83% in 18 sessions. And this meta-analysis by Liu and others showed that if we use a correct high energy flux density, we get better results. An EFD of 0.09 millijoules per square millimeter is better than the lower ones. And when we use more shock waves per treatment, 5,000 over 1,500, we have increased IIEF scores. And when we finish it in 6 weeks, it's better than when we finish it in a longer period of time. And if we do more sessions, we get better results. How should we perform it correctly? This is a key thing because sometimes we don't pay attention to that. It depends on the machine we're using. If we use the ED1000, for example, you have to have a very good grip of the penis in order to have good contact of the probe with the skin. If you use the Direct machine, the Renova, you have to use the arm. Or if you use the Wolf machine, you have to use a stand. You have to have the penis straight and not moving. Pubic hair should be shaved, and please always inspect for contagious lesions. Treat them first. Use generous amounts of gel without air bubbles. Cover the full length of the corpora, and if you have to move the probe, move it slowly, don't lose contact. And always pay attention to the crura, they are the most tricky part. It is clear that it will not benefit every patient. The study by Kitri, which is very, very recent, it was published in July, showed that severe erectile dysfunction with an IIF score less than 10, or if there is no tumescence at all, is a very bad indication for shock waves. Shock waves should not be offered in such patients. There was also evidence that non-response to PDE5 inhibitors and injections is not a good prognostic factor. The elderly patients is questionable as to whether they could have a good outcome from shock waves. Also, post-radical prostatectomy and neurogenic erectile dysfunction is a big question as well. There is no data regarding to which machine is better. We always have to consider probe warranty and replacement costs because these things are expensive. It's always good to have a light and versatile probe because it helps your everyday work. And you should always try your machine before buying it. Ballistic machines currently are not good choices. The optimal treatment protocol is yet to be defined, but it is evident that there is a minimum requirement of 12 sessions. It's better to use more pulses per session. 5,000 is the optimal right now. And the EFD should be in the range of 0.09 to 0.11 millijoules per square millimeter. It's safe to perform up to 3 sessions per week, and there's no need for a gap in between. If you have a patient that has not responded very well, please don't hesitate to offer him 6 additional sessions. It may be converted to a responder. And don't be afraid to do shock waves in patients who are receiving anticoagulants. So do we need it? The answer is a clear yes. It is very safe, it's non-invasive and can be repeated at any given time. It is effective in mild to moderate erectile dysfunction and seems to have durable results up to 2 years. It can replace oral treatment in patients who previously responded to PDE5 inhibitors, and that's a good thing for them. And it can sift about half of non-responders to responders. It's clear that we need more basic research and RCTs with long follow-ups, maybe up to 5 years, and also more patient-friendly devices and treatment protocols. It is my conclusion that low-intensity shockwave therapy is shifting the paradigm, and we are moving slightly from symptom relief and mechanical assistance to disease modification and prevention. And a brave new world is coming upon us. Thank you very much.